Dr. Kelly Dunn is a leading researcher in addiction science from the University of Maryland. She has been a driving force in the field of opioid use disorder and withdrawal management since 2005, and she served as the principal investigator on over $20 million in funding from the NIH on drug abuse. Hopefully that hasn't been pulled. Dr. Dunn's work explores a critical question: can cannabinoids be used alongside opioids to improve therapeutic outcomes and reduce harm? Her studies provide essential insights in how these substances interact and what it means for both risk and efficacy in clinical practice. Please join me to welcome Dr. Dunn.
Hi, everyone. Thank you for the opportunity to talk to you today about our data, and thanks so much for the talks leading up to this that have really nicely set up the conversation that I wanted to have. So I've worked for a long time in the area of opioid use disorder, and I've come about I guess I've come into the area of cannabis research from that perspective, largely following on the points that Dr. Walsh made just previously, where we were looking at ways to either improve pain for people that had opioid use disorder, improve outcomes for the treatment of opioid use disorder, or trying to look at opioid-sparing effects that cannabinoids may have. And so I thought I would just move into kind of set up some of the background of this and then talk about some of the laboratory trials that we've done. So there has been a long history of meaningful opioid-cannabinoid interactions. There's actually reports back in the 1800s where people were reporting using cannabis products to help treat laudanum addiction. And so, and I'll show you in a moment, there's some preclinical basic science data that really support this as well. In our field, when we're trying to address harm reduction and reduce the number of people that are experiencing opioid use disorder or fatal or non-fatal overdose, we've had a lot of conversations about opioid-sparing medications, which means something that we could give to layer on top of the opioid to reduce the quantity of opioid that somebody needs to consume in order to achieve their effect. And then, of course, there's a lot of signals suggesting that if we combine cannabis, which was really nicely set up in the last talk, if we combine cannabis or administer it to people who are in treatment for opioid use disorder, it seems to have some benefits. And there's also been really strong vocal advocacy from patients throughout the country, throughout the world, who report that they need access to cannabinoids, medicinal cannabinoids, to be able to reduce or to improve their pain management. And these are often people that are receiving opioid medications, and they're saying, I really need to continue having access to these cannabis products in order to, because they're really helping with the opioid medications. And so from our perspective, we're thinking maybe we could leverage this and actually reduce the reliance on opioids. So let me go through a little bit of this preclinical data just to show you how we got to this point. And so the work that I'll be talking about, we started probably about 10 years ago, and at the time there weren't many human studies that had looked at these interaction effects, just a couple, but there was an abundance of animal data. And you can see this is a study that was done in 1975. What you're seeing here is it was an animal study where they administered THC at various concentrations to animals, and then also CBD as well. And what they could do is if they had an animal that had just morphine exposure and they administered naloxone, which is the narcotic, the antagonist, which is Narcan, to reverse or to precipitate a withdrawal syndrome, they produce a very significant withdrawal syndrome. But if they pre-treated with increasingly higher doses of THC, they reduced the severity of that withdrawal syndrome, and that was specific to THC and not CBD. So this is one of our kind of first signals that there's a meaningful interaction between these compounds. When they took it a step further, you can see this again is an animal study where you're looking at increasing quantities of morphine exposure, the opioid morphine, and then the percent of the effect up here. And this was a tail flick test, and what you could see is when you administered morphine to an animal, this is kind of the standard pain response that animal would have. As the doses of morphine increased, you had greater analgesia that was being produced. But when it was combined with doses of THC that increased in concentration, you shifted that. So you needed to give a smaller dose of morphine to be able to produce that same effect, or maybe even a more efficacious effect. So again, a suggestion that there are meaningful interactions between these compounds, and all of that was blocked if you pre-treated it with naloxone. So you eliminated the opioid effect, you also, the THC didn't have the effect. So it was an interaction, right? That's the thought behind this. And importantly, a lot of the early data were really focused on morphine, but these data suggest that it was not specific to morphine. So these are the same concept here, where these are 4 different types of opioids, the dose across the x-axis here, and you see in all cases you could produce analgesia with these different opioid doses, but when you pre-treat with a dose of THC, then you shift that. You can reduce the amount of opioid that you need to produce the same effect. So collectively, this suggests that there's meaningful interactions in animal research to suggest that there's value in pursuing these interaction effects in people. And then finally, what these data suggest is that THC, when you administer it with opioids, can actually enhance a dose of the opioid that is otherwise subtherapeutic. And so on these 2 figures here, you see these are animals that receive morphine, and these are animals that receive codeine. The filled bars are just THC by itself. The open bars are the opioid by itself, and then the hashed bars are the opioid and THC combination. And you can see in all of these cases, if you just look at morphine for an example, as time goes on, and again, the better effect is the higher effect, you see that the opioid itself produces a very small effect, as does the THC, but when they're combined, that's when you get the big effect. So that perhaps speaks to this opioid-sparing concept, that if you have a dose of an opioid that's working okay, and then you can layer a cannabinoid on it, maybe that'll boost it into a much more efficacious state, which would prevent us from having to increase your opioid dose. That's the kind of the goal here. So there are more preclinical data as well, but there was just this convergence of data suggesting that animal studies are showing this really meaningful effect. And then we had the famous study that demonstrated a signal in the epidemiological literature, which again was an epidemiological report suggesting that as states had made medicinal cannabis available, we were seeing associated reductions in the rates of overdose in those states. And so the implication was that as people can shift over from opioids to cannabis, their prognosis is improved, right? There's less of an need to increase their opioid dose or to incur some opioid consequences. As was pointed out, that effect did reverse, and so this is a time point that was reflected in that prior data set, and you can see that there was a slight reduction in opioid-related overdoses that subsequently changed, and that probably a lot of that has to do with changing of the opioid product as well. But this isn't the only study to suggest that, as we've already learned. And so collectively, we have this really large body of animal work suggesting a positive interaction effect, and then these epidemiological signals suggesting to us that maybe this is true in the real world as well. And then if we look in the context of people with opioid use disorder, we saw, this is a summary of a variety of different studies that showed us the same benefit of these interactions. So overdose in people who were maintained on methadone and were using cannabis regularly decreased. It decreased in locations that had more cannabis dispensaries. Presumably, they would have more cannabis access. Individuals who were co-using cannabis with opioids and had chronic pain reduced or didn't have as high a dose of prescription opioids. They had improved quality of life, and we saw reductions in the rate of injection drug use in people who were injecting drugs. So again, collateral suggestions that this is a meaningful area to look. And so we set out to look at, I guess these are the 3 converging areas that really prompted us to do this, the next series of studies that I'll talk about. And that was to explore the therapeutic value, to look at whether or not we could find a signal for an opioid-sparing effect of cannabis, and then to understand the basis of these epidemiological reports. And at the time that we started this work, there were maybe 2 or 3 laboratory studies that had looked at this. And in those cases, I think that they were predominantly smoked cannabis. And they all seemed to find that a very, very small dose of smoked cannabis would have a benefit, but that it was kind of quickly washed away with higher doses of cannabis. And we were really interested in modeling what would happen in a prescriber setting, in a provider's office, knowing that they wouldn't be able to prescribe smoked cannabis. And so we stuck with the FDA-approved forms of THC, of cannabinoids, so that we can kind of model what would happen, an opportunity, so that if we found a beneficial outcome, people can immediately start to prescribe those medications. And so this is our kind of study design. So I'll take a moment to explain this, because we've there's 3 studies that have the same kind of general design. So we also did, similar to the talks earlier today, within subject studies that were highly blinded. We enrolled people that were from the community, they were healthy individuals, and they had no history of drug use disorder, of opioid exposure, and no 30-day exposure to any sort of substance. And so these were really drug-naive individuals, again, modeling what would happen if you went into your doctor's office with pain and they were going to prescribe something to you. This was a within-subject design. The first dose, in this study we tested 4 milligrams of hydromorphone, which is an opioid agonist. It's a moderate dose of the opioid agonist, and on day 1, and all of their dosing, we actually call this triple blinded, meaning that if people, not only do the participants and the staff not know on any one day what people are receiving, but the participants don't even know the compounds under investigation. Nobody does. So we kept it so blinded that there was no bias, no opportunity for them to understand that they were experiencing an opioid or a cannabinoid effect. But we had everyone come in on day 1. We gave everyone the same non-randomized dose of just opioid by itself to make sure that they could tolerate it. And then we transitioned them into, as long as they did, meaning that they, usually if they didn't tolerate it, they would throw up. There was no serious adverse events in any of our studies, and we took care of everyone. But as long as they could tolerate that, then they moved into a within-subject design that was randomized, and they received placebo, and then the same dose of hydromorphone with increasingly higher doses of dronabinol was the cannabinoid that we were looking at. And we followed the FDA guidance for how you assess drug effects. So the FDA has very structured recommendations of the measures that you should collect and the frequency that you should collect them. And so we just used that same guidance to be able to assess the outcomes here. And so every day people would come into our sessions and we would give them these triple-blinded medications, collect self-report, physiological ratings, observer ratings, blinded observer ratings, and we also would do empirical pain testing. And so this was a quantitative, it's referred to as quantitative sensory testing. We had 4 measures that were eliciting a model of acute pain. So this is a cold pressor test, this is pinpricks, temporal summation, we have pressure pain that's pushing into the muscle, and then we also had a thermode that was delivering heat. And then we had, in addition, a model of chronic pain, which is a capsaicin cream. So if you've ever used capsaicin, you can buy it over the counter, I think, for 0.1%. It's meant to, it produces kind of a diffuse, slightly tingling, burning sensation. This was a 10% cream, so it really produced a pretty strong effect. And what we could do is we would expose the person to it and then be able to rekindle it throughout the day. And so whereas all of these models produce a more kind of acute pain model, the capsaicin produced this kind of diffuse, rekindled pain throughout the day. In all of these cases, participants knew exactly what they were consenting to, and the primary outcome was the length of time that they wanted to tolerate the pain with upper limits set on it, so we wouldn't cause any sort of damage to people. So they were always in control of how much pain they experienced. And so these were our outcomes, and then we looked to see whether or not we found significant differences between the groups. And what I'll show you here across the bottom, these are the different conditions. So this is placebo, hydromorphone only, and then hydromorphone with those increasing doses of dronabinol. And these are just 3 of the pain outcomes that we're reporting here. So these are the thermal threshold, which is the point at which they could detect the thermal pain, the heat pain. This is the tolerance, so it's the point at which they said that the pain is severe enough that they wanted to stop. And this is just kind of a global measure of central sensitization. And what we see here and what we saw across the board is if we saw any effect at all, we only saw it in the smallest dose of dronabinol, and as soon as the doses increased, then we lost that effect. And that was entirely consistent with the reports that we were seeing from the other laboratories as well. And so this is just not consistent with what patients tell us in the real world, right? And so we had multiple studies, now ours as well as a couple others, that all found the same effect, and it is not consistent with people telling us I have to have access to these cannabinoids to treat my pain. And so the question is, why is our effect so reliable and so not inconsistent with what people are telling us? And so, again, because we approach this from, well, actually, sorry, I got ahead of myself. I'll show you also the drug effect ratings before I go into this. So this is the placebo, hydromorphone by itself at 0, THC and then increasing doses of THC. And these are the self-report outcomes that we assess. This is what they actually look like over here, and this is the FDA guidance for how to do that. And we ask some broad questions. Do you notice any drug effect? Because we don't want to assume that we can predict what the drug effect is that they'll experience, just broadly, any drug effect, any bad effects, whatever they may be, a high and nausea. And you can see generally that we didn't see a big differentiation, right? So once we added THC, it didn't jump much from what people were experiencing with just hydromorphone, and we saw that kind of across the board. Okay, so going back to my prior comment. Remember, we approached this from the perspective of opioid mechanisms of action and opioid use disorder, and we know in the opioid field that there's this really compelling finding of individual differences. And so this is a study to demonstrate that. These are people that had opioid use disorder, but were currently abstinent, and they enrolled in a residential trial where they lived with us for several weeks, and they received doses of intravenous heroin or intravenous hydromorphone, and they were looking at the effects it would create. And what you could see is that as the dose increases, these are all drug effect ratings, as the dose increases, so do the effects, right? And that's what you expect. But if you look at the individual variation, these different data points, these are all the individual people, you'll see that there are some people that had very low effects, even at high doses of intravenously administered opioids, and then other people that had very high effects. And if you look at this across time, you can actually see this, I think it's depicted really nicely. These are all the different measures, all the different ways of asking people their drug effects. And you can see these, and this is the same organization across the bottom here. You can see that there are some people that just have these conventional dose-dependent responses, and there were other people that did not. They did not respond to these medications. And this is now a finding that our lab has found in multiple different trials. In fact, I think that we've collapsed now over 200 participants in these very rigorous within-subject designs with different forms of opioids and different administrations. And routinely across the board, we find that about 30% of people are not detecting the drug effect. And so, and this is an example of this. This is a group of 75 individuals that received access to different doses of hydromorphone, and we looked at what's the dose where they first detect the drug effect. And we had 20% of people that could detect as low as 2 milligrams, and about 30 or 42% of people that could detect at 4 milligrams. Some people, they had to have an 8 milligram dose of hydromorphone, which if you're familiar with that, for an opioid naive person, that's a pretty whopping dose. And then again, we had about 30% of people, 27%, that never detected any of it. And so we went back and looked at our data and said, could this be actually some of the reason that we're not seeing this relationship in our cannabinoid data? And so I'll show you these data again. Again, these are drug effects and high, and these are individuals who were responsive to the opioids, and these were the individuals who were not. And so just to take a moment and look at these folks, again, you could see that their rating of drug effect for the opioid was very low, consistent with them not being a responder. But then when they had the dronabinol doses, that's where we had the drug effect. And it wasn't as high as the opioid effect, but it was a prominent drug effect, whereas the opioid responders had hit a ceiling. So when they had that, the effect that they experienced was really driven by the hydromorphone, and adding that the dronabinol really didn't do much more for them. And we saw that to be true with ratings of high and all these other ratings as well. And so it was understanding that some of these folks are not experiencing the opioid effect, and that in those cases they are experiencing or able to differentiate, whatever it may be, they're able to differentiate the cannabinoid effect. And so let me show you a second study where we've looked at this. So this is the same design as what I just described, but we swapped out the cannabinoids. So in this study, we used cannabidiol, specifically Epidiolex, because that was commercially available and available for prescription in the United States. And it's the same exact design otherwise. The patient population is the same. They were different people. We required that they were different people, so it's not an overlapping population, but otherwise all of the outcomes were identical. The team didn't even really know that we had made a shift. And again, we see the same kind of relationship, that in this case, the arrow points in the direction of the beneficial effect. You can see if we look at things like cold pressor, the point at which they could detect the effect, we saw a slight increase in the cannabidiol conditions. And let me just back up to say we tested 50, 100, and 200 milligrams of cannabidiol. And I know that kind of anchoring it to Jasmine Hurd's data that we saw presented earlier, recognizing that 200 was the highest dose that she would give at any one time. So we saw a slight improvement of pain in these higher doses, and a slight decrease here, but kind of, as, again, not dramatic, not consistent with what people tell us. And then when we looked at the drug effect ratings, we saw the same thing if we look at it combined, right? So this is ratings of drug effect, where this is a hydromorphone-only condition, and then the cannabinol conditions, we really didn't see much of a benefit. And the same is true for bad effect. But once again, when we shift and look at it as a function of responder, that's where we see the effect emerge. So in the opioid responders, when they had access to the CBD, they had really already ceilinged, right? So they had a little bit higher of an effect, but not much. But the non-responders were the people that were experiencing the drug effect. And the same was true over here as well. And in this case, actually, the CBD seemed to make the opioid effect a little bit more negative for the responders, but not the non-responders. And I'll say that what we're speculating is that CBD is actually interfering with the metabolism of the opioid, and that maybe that's what's producing these effects, because we also had really prominent next day effects for people that were opioid responders but not non-responders. And then finally, just one last study to talk about. So this was a study that was done in people that had chronic pain, recognizing that we're studying pain in people that are otherwise healthy, but somebody who's had pain for a long time may have neuroadaptations that have occurred that would have them respond differently to medications. And so in this study, this was individuals who had knee osteoarthritis. They tended to be a little bit older because of that. But the same idea that we enrolled them, they had the 4 milligram hydromorphone condition. And then we only had 3 randomized conditions. We had one that was a placebo condition, one that was only 10 milligrams of dronabinol, and one that was a combination of opioids with dronabinol, the hydromorphone and dronabinol. But otherwise, everything was the same pain ratings, the same design of the study. And again, what we found in this study was that these are the individuals with hydromorphone only. We'll just look at cold pressor here, dronabinol by itself, and then hydromorphone by itself. We saw that the dronabinol actually seemed to increase the sensitivity a bit, but when combined with the hydromorphone, that's where we were seeing the strength of the effect. So it was that kind of combined effect. And that was across the board with these various different outcomes that we were looking at. But when we looked at the drug effect ratings, once again, we have this kind of dose-dependent increase when we had the 2 active drug conditions, the placebo and then the dronabinol, as well as the combined. But when we look at it as a function of opioid responders here, we see that the effect really differentiates. And in this case, if they were opioid responders and they had only the dronabinol, they had a prominent drug effect, right? And these are people who have a history of chronic pain. Probably, they certainly had a history of of consuming opioids at the past. They weren't tolerant at the time. And the same is true here as well when they had the combined effect. Even though they weren't experiencing the hydromorphone by itself, they did experience it when it was combined with dronabinol, probably driven by the dronabinol effect. And that was true across all the outcomes that we looked at. And so just to quickly summarize, these are the effects that we found. Really, across all of these studies, we now have a 4th one as well where we've reduced the opioid dose. We don't find across the board when we average this a major robust effect of opioid sparing or even opioid cannabis interactions, but we find it routinely if we pull apart the individuals based on whether they are sensitive to the opioid effect. And so for me, what I take from this, again, trying to reconcile the epidemiological literature, the theory that we're working under, that we're trying to investigate now, is whether those folks who are in the real world and are saying we need access to these cannabinoids to help with our opioid pain management, if they are really not sensitive to opioids. And this is a topic that we have talked about in the field, and we kind of understand exists, but a lot of the data that has looked at the responsiveness of opioids in people has been in people that have pain. And so we often attribute it to their pain condition, right? That it's like, oh, I didn't realize that their pain was so severe, or they've got other things that are happening, we need to adjust their opioid. But our data are showing that this exists in people before they've ever even taken opioids, right? This is just it's a trait of the person. And we don't know why, and we're exploring that as well. But our speculation is that the data that we're finding is actually consistent with the epidemiological data, and that it is the people that are not receiving benefit from the opioids or who can't detect the opioids who are feeling that they need to have access to these cannabinoids, and that really what they're having is not necessarily an interactive effect, but actually a cannabinoid effect that they are attributing to an interaction. And I think, going back to the conversations that we heard earlier today, I think this has been really helpful to me to hear the discussions and certainly the panel with people that have the lived experience, because I think I often think about stigma in the context of opioids, which is a highly stigmatized condition. But this makes me realize that helping people become aware and maybe building this idea more, building a larger empirical base for this hypothesis would be helpful, because if people understood that not everyone, just at the base, not everyone is going to be responsive to opioids in an optimal way, and that it's important for those people, once you understand that, to kind of quickly shift them to other medications so that you're not continuing to push the dose up, because that's what tends to happen. And what we know from the opioid field is there's two things that predict the transition of prescribed to problematic opioid use, and that's having a higher dose or taking them for longer periods of time. That's robust predictors. And my speculation, my hypothesis is that if you are unaware that if you can't detect the opioid effect, you're probably more likely to go back and request higher doses or to try longer to take these medications to see if they would work, and that would independently increase your risk for other consequences related to it. Plus, perhaps not be an efficacious form of treatment for you. So our conclusions are that the effects of these combinations really varied a bit dependent on the cannabinoid that was administered, but really largely on the responsiveness of the person to opioids and their clinical pain status as well. Dronabinol in our studies had a very narrow therapeutic window, and we also had an increased risk of AEs. So it was only a 2.5 milligram dose of dronabinol that seemed to benefit these patients, they're not patients, these participants. And as soon as we doubled that dose, then they just incurred negative consequences and bad effects, but they had no benefits to analgesia when we looked at them together as a group. And cannabidiol seemed to enhance the effects of hydromorphone, which we are hypothesizing is related to a metabolic interaction. So the future directions, we've explored now the sensitivity concept in multiple different studies, really as an ad hoc secondary analysis, understanding, kind of recognizing that that's what's happening in our patients and our participants. But I know nothing about whether this exists in other areas, right? We don't know if there are cannabinoid responders. Our data kind of suggests that there might be, but I think it's something that's worth considering. We certainly would need to do studies where we're looking at THC only. We looked meaningfully at the interactions, but it would be important to understand the THC only condition, or the cannabinoid only conditions, I should say. And then the drug-drug interactions as well. The study that we ran with individuals who had pain, for instance, we screened 102 people. They couldn't be on any opioids or cannabis products to be in the trial, but they were taking 199 different medications across the people that we looked at. Only 2% were not currently on a medication. Some people were on as many as 19 medications and had been consumed for up to 28 days. So we tried to standardize it and control for it as much as we could, and it was a within subject design, so that was, as long as it stayed stable, we could derive some value from it. But these are difficult studies to run because of that, and there's our interest as pharmacologists is to pull apart all these drug-drug interactions, so that can be a bit challenging. So I'll end and just say, I'm happy to talk more about these research. There's a large group that contributes to this, and they were all funded by the National Institutes on Drug Abuse, and they were conducted while I was at Johns Hopkins, and I've now moved over to the Kahlert Institute for Addiction Medicine at the University of Maryland, and hope that you follow us to see more of the work that we're doing in this area. Thank you.
Thank you, Dr. Dunn. We do have time for one question. Well, if not, you can find Dr. Dunn just over here, and I really appreciate the time you took and made it out here to the north of the border. The work that you're doing is very important to both understand in terms of what we're seeing in opioids and cannabinoids, but I think it does raise the question on cannabinoid responders, and we do see that in other populations, and at CCIC, the McMaster group identified some similarities to that work, that there was responders and non-responders, and it isn't a treatment for everyone. So I appreciate you showing that work.